A patient with a pacemaker coming for transurethral resection of the prostate. May I request the postgraduate from NRI Medical College, Dr. Shushma Reddy, and the examiners for this case discussion, Dr. Jafra Mehdi, Professor, NRI Medical College, Tagarappu, Valsa, Dr. Kota Chandrasekhar Sir, Professor and Head of the Department, Gayatri Vidya Parishad, and Dr. Pratibha Natarajan Ma'am, the guest speaker for today. Please go ahead.
Good evening, everyone. Thank you for the opportunity. And today's case discussion, it is pacemaker patient for TURP surgery. I am Dr. Sushma, postgraduate from NRI Medical College, Sangivalsa. Moderator for today's session is Dr. Zohra Mehdi, Professor, Department of Anesthesia. Coming to patient details, a 70-year-old male hailing from Bhimili who works at a hotel came with complaints of increased frequency of micturition since 2 years, dribbling of urine during micturition since 2 years, and sense of incomplete bladder emptying with weak urine stream. Coming to his history of presenting illness, patient was apparently normal 2 years back. Then he noticed increase in frequency of micturition. He had to wake up in the middle of the night with the urge to pass urine. He also complains of weak urine stream with a sense of incomplete bladder voiding post-micturition. There is no history of trauma, no history of pain while urinating or blood in the urine. There is no history of significant weight loss or loss of appetite. No history of fever or pain abdomen or vomiting. No history of previous catheterization. His past history, he did not have any similar complaints in the past. He was diagnosed with hypertension 10 years back and was started on tablet amlodipine 5 mg OD. Patient had history of multiple syncopal attacks since 2021. He was then taken to hospital and further workup was done. He was diagnosed with 6 sinus syndrome and underwent a pacemaker insertion in 2021 under local anesthesia. Review of pacemaker function and battery status were assessed 1 year back. Pacemaker was functioning well at that time. History of prostate biopsy 10 days back under local anesthesia was done. Pacemaker details were taken from manufacturer booklet. Medtronic permanent pacemaker with DDR mode was installed in 2021, which is buried in the pocket superficial to pectoralis fascia on the left side and set at a rate of 70 per minute with a battery life of 5 years. Since then, patient did not have any similar attacks. There is no history of diabetes, thyroid disease, renal or liver disease, cerebrovascular accidents, bronchial asthma or valvular heart diseases. No history of palpitations, syncope, facial edema or pedal edema, snoring, orthopnea or PND. He did not have any blood transfusions in the past. Coming to his family history, there is no history of any similar illness or significant comorbidities like diabetes, hypertension, ischemic heart disease among the family members. There is no history of valvular heart disease or dyslipidemia or congenital heart disease or sudden cardiac deaths among the siblings. He belongs to a middle class family. Personal history, he is on mixed diet. His sleep is disturbed due to nighttime awakenings to pass urine. Bowel habits are regular. He is non-smoker and non-alcoholic. Coming to his medication history, he takes tablet amlodipine 5 mg OD, tablet aspirin 75 mg OD, and tablet atorvastatin 40 mg OD. General physical examination. Patient is conscious, coherent, and oriented. He is moderately built and well nourished. His height is 170 centimeters, weight 62 kgs, and of BMI 21.5 kg per meter square. There is no pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy. There is no pedal edema or varicosities. Skin tags of xanthelasma are not found. His spine, there is no kyphoscoliosis. Spinous processes are palpable. Patient is catheterized. His JVP is not elevated. Pulse rate 70 beats per minute, regular in rhythm, normal volume and character, normal vessel wall, and all peripheral pulses are palpated equally. Blood pressure is 136 by 90 millimeters of mercury over right arm in sitting position. Respiratory rate is 16 per minute, abdominothoracic pattern. His saturation is 98% on room A. Patient is afebrile. Airway examination. Upper airway is normal. There is no facial dysmorphism. There is no bucking of tooth, no loose tooth or missing tooth or artificial tooth. His mouth opening is more than 3 finger breadth. Malampati classification is grade 2. Thyromental distance is 7 centimeters and his neck movements are mildly restricted. Coming to cardiovascular system examination, on inspection, chest wall is bilaterally symmetrical in shape. There is no precordial bulge. Apical impulse is not visible. There is no engorged or visible pulsations. Scar is present in left subclavian region along the infraclavicular line. On palpation, apex beat is felt in left fifth intercostal space in mid-clavicular line. There is no parasternal hip. There is a palpable pacemaker in the left subclavian region. On auscultation, S1, S2 sounds are heard. There are no murmurs. Respiratory systemic examination, normal vesicular breath sounds are heard. There are no added sounds and trachea is central in position. Abdomen examination, all quadrants are equally moving with respiration. Skin over the abdomen is normal and there is no organomegaly. Central nervous system examination, there are no focal neurological deficits. Sensory and motor system are within normal limits. Investigations, complete blood count, hemoglobin is 12.5 gram per deciliter, hematocrit is 38%, platelets 2.3 lakh per millimeter cube, and total leukocyte count is 6,000 cells per cubic mm. Coming to his renal function test, urea is 36 milligram per deciliter, creatinine is 1 milligram per deciliter. Coagulation profile, prothrombin time is 15 seconds, INR is 1.1 and APTT is 34.8 seconds. Blood group is A positive, random blood sugar is 112 milligram per deciliter, serum sodium is 143, potassium and chloride 116 milligram. His ECG, heart rate is 70 per minute, pacing spikes followed and QRS.
May I request someone, please stop cross talks, please.
On chest X-ray, lung fields are normal. Pacemaker can be seen implanted below the clavicle and the leads are intact. 2D echo, there is no regional wall motion abnormality, no LV diastolic dysfunction, no PAH, no hypokinesia. Mild concentric LVH is present with ejection fraction of 56%. Ultrasound abdomen, urinary bladder is distended and normal. Pre-void volume is 280 cc. Post-void volume is 50 cc. There is no significant post-voidal residual urine. Prostate is increased in size with a volume of approximately 42 cc. Impression of ultrasound, grade 2 prostatomegaly. Summary, a 70-year-old male, known case of hypertension and sick sinus syndrome with permanent pacemaker in situ with diagnosis of benign prostatic hypertrophy is posted for TURP surgery.
Okay, now since your patient is a pacemaker patient posted for TURP surgery, we should know something about the pacemaker. So what is a pacemaker and what are the indications of pacemaker?
Pacemaker is a device that delivers controlled rhythmic electrical stimulus to the heart muscle in order to maintain an effective heartbeat and thereby ensures pumping capacity of the heart to make sure adequate cardiac output is present. Indications of pacemaker implantation. It is acquired AV block. It can be secondary degree AV block or third degree AV block after myocardial infarction, bifascicular or trifascicular blocks, sinus node and AV node dysfunction, hypertensive carotid sinus and neurocardiac syndromes, prevention and termination of arrhythmias by pacing.
What are the various types of pacemaker and what are the generic codes used for that?
Types of pacemaker, depending on duration, it can be temporary pacemaker or permanent pacemaker. Temporary pacemakers are placed for a few weeks or for few days after cardiac surgery or after myocardial infarction before the treatment. And permanent pacemakers, they are placed permanently below the left clavicle. Depending on method of insertion, we have epicardial pacing, endocardial or transvenous pacing, transcutaneous pacing and transesophageal pacing. Epicardial pacing, the leads are placed, the pulse generator is placed below the chest, and in endocardial or transvenous pacing, through the femoral vein or IJV, the leads are passed and the lead is placed in right atrium and which enters into the right ventricle to pace the heart. Transesophageal pacing, it can be either through pill or through a flexible catheter. In conscious patients, we'll ask the patient to swallow the pill and through that pacing will be done. And in unconscious patients or intubated patients, through a flexible catheter, transesophageal pacing will be done. Depending on location of leads, it can be single chamber pacemaker, dual chamber pacemaker or biventricular pacemaker. In single chamber pacemaker, the leads are placed in the right ventricle. In dual chamber pacemaker, the leads are placed in both right atrium and right ventricle. In biventricular pacemakers, the leads are placed one in right atrium, other in right ventricle, and the other is placed in coronary sinus. Coming to generic pacemaker code, no discussion of pacemaker is complete without discussing generic pacemaker code. This was given by North American Society for Pacing and Electrophysiology in 1983, which was revised in 2002. Generic pacemaker code describes the behavior of the pacemaker. It describes there are 5 positions. Position 1 is for pacing chamber. Position 2 is for sensing chamber. Position 3 is for response to sensing. Position is for programmability and position 5 is for multi-site pacing. In this, O indicates none, A indicates atrium, V indicates ventricle and D is for dual. That means atrium plus ventricle. In response to sensing, O indicates none, I indicates inhibition, T indicates trigger and D indicates dual. That is I plus T, both inhibited and triggered. Programmability is O is none and R is rate modulation. Coming to parts of a pacemaker. In pacemaker, there will be a pulse generator, leads and the electrodes. Pulse generator, it is made of titanium, which is very much lighter than the steel and is 10 times more stronger than the steel. In this pulse generator, we have a battery made of lithium. Lithium has long shelf life. That's why lithium made batteries are preferred. And the leads, they are placed in the chambers of the heart. The leads connect the electrodes and the pulse generator through which stimulus is transferred.
What are the common terminologies used in pacemakers?
Some common terminologies used are initially unipolar pacing. Here there is only one electrode. The impulse flows through this tip electrode, which stimulates the heart and returns to the anode on the casing of pulse generator via adjacent tissue to complete the circuit. In unipolar pacing, the pacing spikes are large and the QRS is broad. In bipolar pacing, here there are 2 electrodes. Impulse flows through the tip electrode located at the end of the lead. It stimulates the heart and this returns to the ring electrode above the lead tip. Here the pacing spikes are small. Coming to pacing threshold, this is the minimum amount of energy required to consistently cause depolarization and contraction of the heart. Pacing threshold, it is measured in terms of both amplitude and duration for which it is applied to the myocardium. Next comes hysteresis. This is particularly useful in patients with sick sinus syndrome. This feature allows a longer escape interval after a sensed event, giving the heart a greater opportunity to beat on its own. Here, pacemaker is programmed to upper and lower rate and a programmable lower hysteresis rate. Sensing. Function of pacemaker by which it senses the intrinsic electrical activity of the heart by identifying the QRS complex or R wave in the ECG. The pacemaker has to correctly recognize the R wave and distinguish it from ambient electrical disturbances as well as from its own T wave. Next comes runaway pacemaker. This dysfunction is characterized by fast and erratic spikes. This occurs generally with generator dysfunction, which can be due to low battery life or battery failure or damage produced by leakage of tissue fluids into the pulse generator. Treatment with antiarrhythmic drugs or cardioversion will not be effective in this case. It is necessary to change the pacemaker to an asynchronous mode or reprogram it to lower outputs. If the patient is hemodynamically unstable, then temporary pacing must be done.
What is cardiac resynchronization therapy or CRT?
Cardiac resynchronization therapy. First, we'll see what are the indications. It is cardiomyopathy, left ventricular dysynchrony, ejection fraction less than 35%, QRS duration more than 150 milliseconds, NIHA grade 3 and 4 breathlessness, and in patients in whom, despite maximum medical therapy, still there is persistent heart failure. In these patients, there will be systolic dysfunction with conduction disturbances. Here, the left ventricle becomes dysynchronous. So there will be decrease in stroke volume, increased wall stress, and delayed relaxation. To overcome this, we will place a biventricular pacemaker. As discussed earlier, there will be 3 leads, one in the right atrium, one is placed in the right ventricle, and the other is placed in the coronary sinus. The right atrium lead stimulates the right atrium. The lead in the right ventricle stimulates the interventricular septum, and the lead in the coronary sinus stimulates the lateral wall of the left ventricle. And the pacemaker can resynchronize a heart to contract in synchrony. This has been shown to be useful in heart failure.
What is pacemaker syndrome and how will you manage it?
Pacemaker syndrome. This is also known as AV dysynchrony syndrome. It represents consequences of AV dysynchrony or suboptimal synchrony. Patient will have symptoms and signs of hypotension, syncope, vertigo, lightheadedness, fatigue, exercise intolerance, weakness, dyspnea, or there can be induction of congestive heart failure also. The main mechanism here is there is loss of atrial kick with resultant decrease in cardiac output. How to manage this? It can be immediate management, symptomatic management, definitive management, medical management, and prevention. First, we'll see immediate management. Here we have to assess the severity of it. We have to check the vitals, how his blood pressure, heart rate, and if there are any signs of heart failure. On ECG, we should check for pacing mode and presence of any retrograde P waves. Immediate device interrogation must be done. For symptomatic management, IV fluids should be connected to correct hypotension. Injection atropine or temporary pacing should be done to correct bradycardia if device failure is suspected. And diuretics should be given for pulmonary congestion. Coming to definitive treatment, aim is to restore synchrony and to eliminate retrograde VA conduction. We have to change the pacing mode from VVI to DDD. We have to adjust timing and optimize AV delay. We have to adjust low rate limit also. If all the above measures fail, then we have to upgrade or replace the pacemaker. Medical management for this, beta blockers or calcium channel blockers to reduce retrograde conduction, rate control in case of atrial fibrillation, and we have to treat the contributing factors. To prevent it, avoid VVI pacing in patients with intact AV conduction, prefer DDD mode in sick sinus syndrome and AV block patient, and program long AV delays to minimize ventricular pacing.
What are the anesthetic concerns in TURP patient with pacemaker?
The major anesthetic concern in a patient with pacemaker is electromagnetic interference with pacemaker with the use of cautery. Also, here we have a geriatric patient with pacemaker in situ and positioning during surgery, irrigating fluid, and post-op management. These are the main concerns. First, we'll say problems due to positioning in this patient. TURP surgery will be mainly done in position. So the systemic changes would be for cardiovascular system, there will be increased venous return, due to which there will be increased cardiac output and increased stroke volume, which causes increased workload on the patient, on the heart. In gastrointestinal system, there will be increased intra-abdominal pressure, which causes regurgitation of the gastric contents, and also there will be prolonged gastric emptying. Respiratory systemic changes include decreased FRC, decreased total lung capacity, decreased vital capacity, and decreased compliance, and there will be VQ mismatch. There can be peripheral nerve injuries like common peroneal nerve injury, saphenous nerve injury, lateral femoral cutaneous nerve injury, femoral nerve or obturator nerve injury. Pressure ulcers can also happen, and there will be difficulty in positioning due to old age. Hip dislocations can occur. Hypotension can occur during repositioning.
How will you evaluate this patient preoperatively?
Preoperative evaluation includes evaluation of the patient as well as evaluation of the pacemaker. First, we'll say patient evaluation. Detailed evaluation of the underlying cardiovascular disease responsible for the insertion of pacemaker should be noted. History of comorbidities and what medication he is using should be noted. And current functional status of the patient should be evaluated by asking about meds. And assessment of cardiovascular system, respiratory system, bone and joint diseases if any, and his liver function test should be evaluated. Mental status is also important because these patients are prone for postoperative cognitive dysfunction. Pacemaker syndrome symptoms such as lightheadedness, dizziness, or fainting should be asked for. And if these symptoms are present, he should be immediately referred to the cardiologist. Coming to pacemaker evaluation, we should know reason for pacemaker mode or demand mode, time since what is the status of pacemaker battery, details of pacemaker from the pulse generator check. We can also or insensitive to the magnet. If there is 10% decrease in rate from time of implantation, it indicates power source depletion. In VVI mode, if intrinsic heart rate is more than set pacemaker rate, heart rate can be slowed down by carotid massage. Other techniques are Valsalva maneuver or injecting hydrophonium injection. We have to check chronotropic response of the pacemaker by injecting low dose of the adrenaline. If heart rate increases, it indicates there is intrinsic rhythm present.
What investigations will you do for this case?
Preoperative investigations required are complete hemoglobin to rule out anemia as well as infection, renal function test and urine routine to rule out urinary tract infections as well as to get his renal functions, coagulation profile, serum electrolytes for baseline electrolyte values, chest x-ray to look for pacemaker placement as well as to check for connectivity of the leads and to also look for lung fields to identify Riehl syndrome and Twiddler's syndrome. 12-lead ECG to look for pacing spikes, rate and rhythm. 2D echo to assess ejection fraction, any wall motion abnormalities, any valvular changes, and also to look for clots, vegetations, etc. Ultrasound abdomen is required to assess pre and post-word residual urine as well as to get an idea about prostate size and the weight.
Now, after evaluation, what are your choices of anesthesia and which anesthesia you will prefer? Modalities of anesthesia and which anesthesia will you prefer and why?
Different modalities which we can do is subarachnoid block, continuous epidural, caudal and sacral blockade, caudal blockade, local infiltration in perineum and prostatic fossa, as well as general anesthesia. Among these, my choice is subarachnoid block. In subarachnoid block, there will be good relaxation of the pelvic floor and perineum, which is easy to the surgeon to operate. As well as in subarachnoid block, patient will be conscious. So it is easy to identify the symptoms and signs of TURP syndrome, which are caused due to fluid overload as well as hypoosmolarity. And we have to limit the level to T10 so that if there is bladder perforation, the patient can experience shoulder pain or abdominal pain, which the patient will complain. So these are the advantages. That's why I'll choose subarachnoid block.
Okay, how will you prepare the patient and the OT for this case?
Preoperative preparation of the patient, NBM orders, high risk consent to be taken, and I'll ask the patient to continue antihypertensives, statins, as well as aspirin on the day of surgery. Anxiolytics must be given before the surgery, night before the surgery. We have to inform cardiologist as well as pacemaker programmer to be available in the OT on the day of surgery. ICU bed should be standby. IV access with 18 gauge cannula and antibiotic and antiacid prophylaxis should be given. OT preparation, we have to make sure temporary pacing, external defibrillator, emergency crash cart, as well as emergency drugs are available in the operating room before the start of surgery. All ASA standard monitors must be available.
What intraop monitoring of the patients you will do?
Intraoperative monitoring includes continuous ECG, peripheral pulse monitoring, and pulse oximetry. Continuous ECG. In ECG, we have to remove artifact filter and then it should be in diagnostic mode. Also, we have to do palpation of the pulse and pulse oximeter should be connected. Precordial stethoscope should be there. NIBP monitoring, urine output, temperature monitoring, and EtCO2 monitoring if the case is taken under general anesthesia.
Okay, so before taking the patient for surgery, you will reprogram the pacemaker. Is it that for every patient you reprogram, or there are any? For every patient you have to reprogram?
It is not
And
necessary.
if so, how?
When the risk of electromagnetic interference is unlikely to interfere with pacemaker, like in surgeries below the umbilicus or the surgery over contralateral arm, surgery over eyes or on face, or surgeries not requiring use of cautery, in these cases, there is no need to reprogram the pacemaker. Also, for patients who are not dependent on pacemaker, as elicited from the history and preoperative assessment, it is better to leave the pacemaker on demand mode. But in all situations, rate responsive function of the pacemaker should be suspended. How we will reprogram?
If you have to reprogram it, how will you reprogram the patient?
To reprogram it, it
Pacemaker.
can be either by magnet or reprogramming software. Advantages of magnet are this can be used easily. It converts to asynchronous mode and deactivates the pacemaker, which can be easily reversed by its removal. If no information is available from the patient about the pacemaker, magnet may identify the particular model with the help of magnet rate, which varies among different manufacturers and thus provides clue for its identification. The disadvantages with magnet are newer devices may not be magnet sensitive and hence may need reprogramming. Placing magnet over the pacemaker can result in Oronti phenomenon or ventricular tachycardias in few patients. It may be difficult to position and secure the magnet in prone or lateral position also. Coming to reprogramming software, the advantages are concerns of magnet like not correctly placed or accidentally getting dislodged is negotiated here. The disadvantages are it needs special software to communicate and reprogram the device. It takes longer time for reprogramming and there remains a possibility that the device may not be reprogrammed at the end of the surgery due to human error.
Describe the effect of magnet application on pacemaker function.
During surgery, as we discussed, there will be electromagnetic interference from the electrocautery. The current from the electrocautery, it is not restricted to the surgical site. It will be passed through overall the body. So this electrical stimulus, it can be misinterpreted by the pacemaker and the pacemaker may stop at that time without giving the electrical stimulus. So this results in decreased output. To avoid this, we have to convert the pacemaker to a fixed rate asynchronous mode by application of a magnet. The magnet is placed over the pulse generator to trigger the reed switch present in the pulse generator, resulting in a non-sensing asynchronous mode with a fixed pacing rate. The effect of placing magnet over the pacemaker can vary quite considerably depending on the device manufacturer, model, individual program modes, and the battery life. In few cases, the magnet may not be effective. Like if magnet application on a pacemaker site does not produce any response, we have to reposition the magnet. If still there is no change, the reasons can be a depleted pacemaker battery, or the pacemaker is insensitive to the magnet, like in companies of St. Jude, Boston Scientific brand, or Biotronic synchronous mode. In these modes, it will be insensitive to the magnet. The magnetic field does not reach the device. Like in cases, if it is deeply seated, like in abdominal or submuscular or in obese patients. Also, if there is end of life or lower battery life, then also magnet will not be effective.
Okay, what are the causes of electromagnetic interference? What are its effects and how will you minimize it?
Causes of electromagnetic interference: electrocautery, monopolar more than bipolar, lithotripsy, external defibrillation, shivering, large tidal volumes, muscle fasciculation, radiofrequency ablations, nerve stimulators, evoked potential monitors, and ECT treatment. Effects of EMI include inhibition of pacing, asynchronous pacing, reset of pacemaker to backup mode, myocardial burns rarely, and also in few cases, ventricular fibrillations can also be seen. How to minimize it? Use of bipolar cautery is preferred. The plate, it must be positioned so that current pathway does not pass through or near the pacemaker. The cautery plates must be placed 15 centimeters away from the pacemaker, and it should be near to the surgical site. They should be positioned such that the electrocautery does not cross the pulse generator or the leads. And electrocautery burst should be limited to 1 second with every 10-second interval. Cutting mode of electrocautery at high frequency, like 2500 Hz, causes more EMI than coagulation mode. Pacemaker should be programmed to asynchronous fixed mode before using the cautery. Also, if a defibrillator has to be used, the pad should be placed in anterior and posterior direction. This minimizes electromagnetic interference.
If the patient develops intra-op VT, what will you do? Ventricular arrhythmias, what will you do? Ventricular tachycardia.
Whenever we see ventricular tachycardia or ventricular arrhythmias on ECG, we have to avoid all sources of electromagnetic interference, remove the magnet, and re-enable therapies through programming if programmer is available in the OT. And we have to observe the patient and observe the ECG. If all these activities does not start the pacemaker function, we have to proceed with external defibrillation or cardioversion. In external defibrillation, we have to place the pads in anterior and posterior directions, and the pads should not be placed directly over the pulse generator. If technically it is impossible to place the pads or paddles in a location that help to protect the pulse generator, defibrillate or cardiovert the patient in the quickest possible way and be prepared to provide pacing through the other routes.
Intra-op, if the pacing spikes are present but not followed by the QRS complex, what does it mean and what is wrong with this page?
If pacing threshold of myocardium increases more than that of the pacemaker spike will be seen on the ECG, but it will not be followed by QRS complex or cardiac contraction. That is, there is failure to capture. This is different from pacemaker failure, where the pacemaker does not fire and no spike is seen in the ECG.
Okay, now coming to TURP, what is the anatomy of the prostate gland and pathophysiology of hypertrophy of the prostate?
Anatomy of the prostate gland. This weighs around 20 grams. It encircles the urethra as it emerges from the base of the bladder. There are glandular and non-glandular components which are enclosed by the fibrous capsule. Coming to its blood supply, arterial supply is by prostatic arteries arising from the internal iliac artery. Venous is by prostatic venous plexus draining into internal iliac veins, which also connects via Batson's plexus into the internal vertebral venous plexus. Nerve supply from prostatic plexus, which carries sympathetic T11 to L2 and parasympathetic S2 to S4. Lymphatic drainage is via obturator and internal iliac lymphatic channels. So here we can see S2, S3, S4, sacral parasympathetic nerves which supplies the prostate, and T11 to L2 which supplies the prostate. Coming to zones of the gland, there are 4 zones: the central zone, the peripheral zone, transition zone, and the anterior fibromuscular stroma. These nodules begin to develop by 4th decade of life in pre-prostatic zone and forms median, lateral, and posterior lobes. There are total 5 lobes. Median and posterior lobes are most often associated with symptoms of urinary tract obstruction. Coming to pathophysiology of hypertrophy of the prostate, hypertrophy results from both hyperplasia of stromal cells as well as epithelial cells. Increased smooth muscle content causes higher alpha-1 adrenergic tone, contributing to dynamic obstruction. Nodular hyperplasia begins in the transition zone around the urethra. Formation of fibromuscular nodules compresses the prostatic urethra, leading to mechanical obstruction.
What is benign prostatic hypertrophy and what are the treatment options available?
Benign prostatic hypertrophy, it is non-malignant enlargement of the prostate due to excessive growth of the glandular as well as stromal elements of the gland. It is commonly seen in age above 50 years and it is the most common cause of urinary obstruction. On histopathology, high alpha adrenergic receptors in the prostatic capsule will be seen as well as hyperplastic prostatic tissue will be seen. Management, it includes medical management as well as surgical treatment. In medical management, we have alpha adrenergic blockers like terazosin, doxorubicin, tamsulosin. Androgen deprivation causes decrease in size of the prostate. 5-alpha reductase inhibitors like finasteride is used to decrease size of the gland. Surgical treatment options available are transurethral resection like monopolar resection, bipolar TURP, laser TURP. Open prostatectomy can be done if the weight of the prostate is more than 100 grams. Transurethral incision of the prostate will be done if the weight is less than 30 grams and obstruction is at bladder or neck. Prostatic stent can be placed. Laparoscopic prostatectomy is also available. Cryosurgery, microwave ablation, and robotic laparoscopy can also be done.
Enumerate the intraoperative complications related to pacemaker and TURP.
Complications related to pacemaker, it can be hypotension, tachyarrhythmia, bradyarrhythmia, myocardial burns, myocardial ischemia, and device malfunction can occur. Complications related to TURP surgery, TURP syndrome, glycine toxicity, ammonia toxicity if irrigating fluid is glycine, perforation of prostatic capsule, transient bacteremia and septicemia, hypothermia, bleeding, and coagulopathy.
What is the role of irrigating fluid, properties of idle irrigating fluid, and commonly used fluid?
Irrigation fluid is used in TURP for 3 main reasons: to facilitate the clear vision of the surgical field, to wash away the blood and dissected tissue debris, and to distend the operative site and increase the visibility to the surgeon. Properties of ideal irrigating fluid include: it should be transparent, isotonic, electrically non-conductive, non-hemolytic, not metabolized, non-toxic, inexpensive, and sterile. Different fluids available are distilled water with osmolality of 0, Ringer's lactate with osmolality of 278, glucose at a concentration of 2.5% and 4.4% with osmolality of 139, normal saline 0.9% with osmolality of 308, urea 1% concentration with osmolality of 167, sorbitol with concentration of 3.5%, osmolality is 165, mannitol 3% and 5% concentrations with osmolality of 275, cytol, which is a combination of 2.75% sorbitol, and 0.54% mannitol. It has osmolarity of 178. Glycine 1.2 and 1.5% concentrations with osmolarity of 175 and 220 respectively. Among these, cytol and glycine are mostly used. In monopolar TURP cases, the electric stimulus, it will be carried throughout the body, not only through to the surgical site. In such cases, when ringer lactate or normal saline is used, the ions will transfer the electric current to the body and it can cause burns. So that's why ringer lactate and normal saline are avoided in monopolar TURP and glycine is preferred. Whereas in bipolar TURP, this problem is avoided and ringer lactate or normal saline can be used.
What is TURP syndrome and what are the signs and symptoms and management of it?
TURP syndrome is a constellation of symptoms and signs primarily due to excessive absorption of the hypotonic irrigating fluid into the intravascular space through open sinuses, resulting in hypoosmolality, dilutional hyponatremia, and fluid overload. Symptoms and signs include in central nervous system, patient will have nausea, vomiting, confusion, agitation, restlessness, visual disturbances, seizure, headache, dizziness, and lethargy. Respiratory systemic changes will be hypoxemia and pulmonary edema. Cardiovascular system, hypertension followed by hypotension, bradycardia, dysarrhythmia, and cardiovascular collapse or arrest can also occur. Hematologic changes, patient can land up in DIC, hemolysis, and anemia due to hemodilution. Renal or electrolyte changes, acute renal failure can happen. There will be dilutional hyponatremia, metabolic acidosis, hyperglycemia, and hyperammonemia if glycine is the fluid. How to recognize it in draw? In regional anesthesia, as the patient is awake, we can recognize it with patient becoming restlessness, dizziness, headache, nausea, or patient having confusion, complaining of pain abdomen, tightness in the chest and throat, if there is decrease in BP or decrease in heart rate. In general anesthesia, there will be rise and fall in BP, that is hypertension followed by hypotension, severe refractory bradycardia, delayed recovery from general anesthesia. On ECG, wide QRS complex can be seen, ST segment elevations, U waves, and ventricular arrhythmias will be seen. Respiratory arrest can also occur if patient is in spontaneous mode. How to manage it? Ask the surgeon to stop the surgery immediately, stop the IV fluids immediately, ensure oxygenation at 8 to 10 liters per minute and give circulatory support. Intubate the patient and maintain with IPPV with PEEP if he is not maintaining spontaneous ventilation. Auscultate the chest for pulmonary edema. If it is present, we have to use loop diuretics like injection furosemide at a dose of 20 to 40 mg. It will be useful for both pulmonary edema as well as renal failure. If patient is having episode of seizures, treat it with anti-epileptics like diazepam or midazolam. And if the glycine is the irrigating fluid, then magnesium will be the drug of choice for seizure. Blood sample should be sent for ABG, serum electrolytes, renal function test, random blood sugar, and hemoglobin. 12-lead ECG must be taken. We have to treat hyponatremia. We have to transfuse packed RBCs if necessary. If still bleeding continues, look for the signs of DIC or primary fibrinolysis. As we discussed, acute hyponatremia can be there. What are the effects? If the serum sodium level is less than 120 milliequivalents, patient will have symptoms of confusion and restlessness, and on ECG, there will be wide QRS complex. If serum sodium level is less than 115 milliequivalents per liter, patient can have hypotension, dysarrhythmia, somnolence, nausea. And in ECG, wide QRS complex, ST segment elevations will be there. If the serum sodium level is less than 110 milliequivalents per liter, patient can land up in seizures or he can go into coma. ECG changes will be ventricular tachycardia and ventricular fibrillation. How to treat hyponatremia? Unless the patient develops severe clinical signs of hyponatremia, Hypertonic saline administration is not recommended. Spontaneous or induced diuresis usually corrects the hyponatremia within a few hours, as it is due to dilutional hyponatremia. Treat mild symptoms of hyponatremia if the serum sodium is more than 120 milliequivalents per liter with fluid restriction and loop diuretics. Treat severe symptoms, that is serum sodium less than 120 milliequivalents per liter with 3% sodium chloride IV at a rate of 100 ml per hour. How to calculate the requirement? It will be calculated in millimoles per liter with a formula 0.6 into weight in brackets desired sodium minus present sodium. Half of the dose which we got will be given in over 8 hours and half over the next 3 days. Monitor sodium levels every hour and do not increase sodium more than 0.5 to 1 millimole per hour because it causes cerebral pontine myelinolysis. Discontinue 3% sodium chloride when serum sodium is more than 120 milliequivalents per liter.
How will you minimize the risk of TURP syndrome?
Precautions to take to prevent TURP syndrome are: use nearly isotonic irrigation fluids, preserve prostatic capsule. We should ask the surgeon to limit number of venous sinuses open. We should avoid bladder overdistension by frequent emptying of the bladder. Intravesical pressure should be less than 15 centimeters of water. Here comes rule of 60. Rule of 60 is limit duration of surgery to less than 60 minutes. Limit height of the irrigation chamber to less than 60 centimeters from the operating table. And staged resection should be done if weight of the prostate is more than 60 grams.
How will you estimate the amount of fluid absorbed?
The amount of irrigating fluid absorbed, it is estimated by comparing sodium levels at any time during the procedure with the levels at start of the procedure. The formula for this is preoperative serum sodium divided by postoperative serum sodium multiplied with extracellular fluid and subtracted with extracellular fluid. Other methods are hematocrit changes, breath alcohol test, weighing patients before and after the surgery, thoracic impedance change, and difference between volume of fluid delivered and aspirated. To perform breath alcohol test, ethanol must be injected in irrigating fluid. Then only we can perform breath alcohol test.
Enumerate the factors influencing blood loss in TURP and how will you estimate the blood loss?
Factors influencing are gland size. For every gram of resected prostate, there will be 15 ml of blood loss. Duration of the procedure, 2.6 to 4.6 ml per minute will be lost, and number of sinuses opened during resection, prostate inflammation and repeated or recent catheterization. Also, here comes type of anesthesia. Vasodilatation will occur due to spinal anesthesia, which leads to pooling of blood in dependent areas, which causes increased venous pressure in the prostatic plexus, leading to increased blood loss. How to estimate it? Visual estimation is difficult as it is diluted with the irrigating fluid. Crude methods like describing from the gland size or duration of the procedure. Quantitative methods like serial hematocrit, calorimetric method, spectrophotometry, and the best way is we have a formula. Blood loss in ml is hemoglobin of irrigating fluid in gram per ml divided by patient's hemoglobin in grams per liter multiplied with amount of irrigating fluid.
Okay, now what are your post-op concerns in TURP and pacemaker patients and how will you manage it?
Concerns with pacemaker. Pacemaker that was set reprogrammed for the perioperative period should be reset to preoperative settings. We should take a 12-lead ECG and confirm the pacing spikes and rate. Multimodal analgesia must be given to the patient. Also, we should maintain normothermia as shivering causes electromagnetic interference. We have to monitor urine output, temperature, blood pressure, and heart rate. Coming to TURP related, we should watch for signs of TURP syndrome, as TURP syndrome can occur both intraoperative period as well as in postoperative period. We should look for signs of bleeding as well as clot retention. And as geriatric patients are more prone for postoperative cognitive dysfunction, that signs also should be looked for. Thank you.
Okay, thank you. Any questions are there in the chat box?
Hello, I am Dr. Ramana Prasad.
Yes.
What is the sensory level you want to obtain for TURP?
T10, sir.
Shushma.
What is capsular sign?
What is?
Capsular sign.
Capsular sign. Okay. See, sensory level can come up to T9, and we don't want to go beyond that, because if there is any bladder rupture or anything, then the shoulder pain cannot be sensed by the patient. So, and why we don't want to go below T10 is because when the bladder is distended, then up to T10 level is the ideal. But sensory level can go up to T9 also.
Capsular sign is perforation of the prostatic capsule. How do you differentiate intraperitoneal and extraperitoneal rupture of the bladder?
If it is intraperitoneal, there will irrigating fluid will be entering into the peritoneal cavity, and it causes distension of the diaphragm.
Distension of
the patient will complain of
the abdomen
or shoulder pain.
What is the cause of dick in TURP?
Sir?
Cause of dick.
Cause of dick.
In prostatic surgery.
It is fibrinolysis, sir.
Prostatic tissue is rich in thromboplastin. And apart from fibrinolysin like urokinase, a patient of a urinary bladder tumor is posted for surgery and is contraindicated for GA. What is your plan of anesthesia? Posted for TURBT, transurethral resection of bladder tumor.
Regional
you can give spinal
anesthesia.
And surgeon says, I am
regional
bothered
anesthesia.
about patient. Surgeon says, I am bothered about spasms.
Obturator nerve block can be given.
No, can be given.